Urinary Cytology, sample adequacy. There should be around 20 urothelial cells per high power field in 10 fields. Add a note if unsatisfactory. Cells should not be obscured. Add a note about obscuring factors if present. Volume should be greater than 30 ml. Note if it is less. If there are 10 to 20 cells per high power field, report as less than optimal. Transitional, aka urothelial cells. Single cells, sheets, or clusters. Can contain glycogen. Cytoplasm is opaque, granular, or vacuolated. Most nuclei are round. Some are irregular or wrinkled. Inflammatory cells are abnormal. Columnar cells may be transitional cells or secretory cells. Histiocytes mimic transitional cells. Superficial, aka umbrella or cap cells, are larger cells, often bi- or multinucleated. Chromocenters, nucleoli, and chromatin rims are more prominent. Can contain mucin. The scallop cell membrane gives it the name umbrella cell. Low NC ratio, cytoplasmic color. Intermediate urothelial cells can be columnar or spindled. Degenerated cells resemble histiocytes because they contain Melamed-Walensky bodies, which are round red to green cytoplasmic hyaline bodies. Prostatic and seminal vesicle cells. Prostatic cells have small homogeneous round nuclei, finely granular or clear cytoplasm. Corpora amylaceae may be nearby. These are small, concentric, non-calcified, cyanophilic concretions. Honeycomb sheets are benign. Acini and macronucleoli are associated with adenocarcinoma. Seminal vesicle cells can be ugly, with big dark nuclei and smudgy degenerated chromatin. Can have golden brown lipochrome pigment. Can have nearby sperm. Renal tubular cells are associated with renal disease such as nephritis, transplant rejection, and renal cell carcinoma. They are small, uniform columnar cells found in casts or sheets, with reactive or degenerative changes often. Cytoplasm may be vacuolated and pigmented. Voided urine. Superficial and intermediate transitional cells should be found. Superficial and intermediate squamous cells may be found more in females. Possible but rare. Seminal vesicle and prostate cells. Inflammatory cells are abnormal. Instrumented urine. These include catheterized urine, washings, brushings, and ileal conduit specimens. They have benign urothelial cell clusters, basal, intermediate, and superficial cells. Ileal loop specimens contain degenerated intestinal cells with Melamed-Walensky bodies, which are a histiocyte lookalike. Upper tract cells can have more atypia, a higher NC ratio, and mildly increased hyperchromasia. Malakoplakia is a granulomatous disease where you see histiocytes with granular cytoplasm filled with bacteria. The cytoplasm can contain Michaelis-Gutmann bodies, which are basophilic, round, lamellated inclusions. Malakoplakia is associated with transplants and AIDS. Some specimens you would see this in are bladder washings and biopsies. Nephrogenic Adenoma is rare in cytology. It's a seeding of renal tubule cells. I remember it as being analogous to endometriosis, but it's not the same process. Cytologically, you'll see small clusters and isolated cuboidal cells. gland-like and papillary clusters, with central nucleus, even chromatin, small nucleolus, regular nuclear membranes, polygonal to columnar cells with high NC ratio, granular or vacuolated cytoplasm, reported as negative for high-grade urothelial carcinoma, associated with renal transplant, upper tract injury or infection, more common in males, average age around 40. Infections that are seen in urinary cytology are Candida, Polyomavirus, Cytomegalovirus, herpes, HPV, Trichomonas vaginalis, and schistosomiasis, which is found in Egypt and increases the risk of squamous cell carcinoma. Polyomavirus is associated with AIDS and organ transplants, and one symptom is hematuria. Big dark nuclei and modest cytoplasm, large round homogeneous blue-black nuclear inclusion, comet cells, which are cytoplasmic tails. Stones, catheters, and stents can cause reactive and degenerative changes, such as enlarged and pleomorphic nuclei, increased NC ratio, chromatin coarse, invariably dark, prominent nucleoli. Stone diathesis, which is stone debris, inflammation, blood, and necrosis. Squamous and glandular metaplasia may be seen. Pseudopapillary clusters may be seen. Low-grade urothelial neoplasia. True fibrovascular core. Doesn't meet criteria for high-grade urothelial neoplasm. Reported as negative for high-grade urothelial carcinoma, or NHGUC. Nuclear grooves, circariform cytoplasmic tails, plasmacytoid cytoplasm. Atypical urothelial cells, AUS. Mild to moderate cytological change concerning for high-grade urothelial carcinoma. NC ratio less than or equal to 0.5 non-basal. NC ratio greater than or equal to 0.5 non-basal cells. One of these criteria: nuclear hyperchromasia, coarse or clumped chromatin, or irregular chromatinic rim. Suspicious for high-grade urothelial carcinoma, SHGUC. Non-superficial, non-degenerated cells with NC ratio greater than or equal to 0.7. Two of the following: moderate to severe hyperchromasia, irregular clumpy chromatin, or irregular nuclear membranes, and less than 5 to 10 well-preserved cells. Other features: eccentric nucleus, prominent nucleolus, necrotic background, pleomorphism, mitoses, apoptotic bodies, and inflammation. High-grade urothelial carcinoma, HGUC. NC ratio equal or greater to 0.7. Nuclear hyperchromasia, irregular nuclear membranes, coarse or clumped chromatin. At least 5 to 10 malignant cells. At least 10 malignant cells in upper tract. Rare hypochromatic variant usually has some hyperchromasia and all other criteria. Degenerated malignant cells are not counted. Renal cell carcinoma. Cells larger than urothelial cells, sparse, single, degenerated. Clear, vacuolated, or granular cytoplasm. Nuclei big and dark, and prominent nucleoli. Prostate Adenocarcinoma. Small, uniform glandular cells with prominent nucleoli, moderate cytoplasm, and microacinar formation. A differential is high-grade urothelial carcinoma with umbrella-like features.